In terms of maintenance and de-escalation, if we look at several studies that have shown that treatment to progression seems to lead to better outcomes, a good example of this would be the first study, where patients were randomized to either receive MPT, RD for fixed duration of 18 months, or RD till progression. The patients who did the best were the RD to progression in terms of PFS. And so I think that sounds intuitive because myeloma we think of as a chronic disease. So if you discontinue therapy, clearly relapses will be more prevalent. The challenge, though, is that in the real world, not everybody's able to maintain these drugs like on a clinical trial. In a clinical trial, we have a cherry-picked population. We have the research team, which includes a physician, nurse, coordinator, who are very motivated to keep people on study. The drug may also be free of charge, so they may not be financial issues. So there's a lot of complexity into why we see that the real-world duration of therapy is much shorter. And I think one of the ways to kind of narrow that gap is to think about being creative with the maintenance strategy. And as kind of we said, we think about the quads as a great example. Yes, quads are showing superiority in initial therapy, but it is going to be impossible to maintain every patient on a quad forever, both from a practical point of view, a medical point of view, from a financial point of view. And so I think that's another area that clearly we may have very potent regimens, but to deliver them in the real world, we're going to have to de-escalate. And I think when we have the different drug classes, historically, what makes a drug ideal for using in maintenance and long-term therapy is oral. And so lenalidomide, for example, is a great option. With the PIs, the only option is ixazomib. DARA, what's nice about DARA in the maintenance setting is essentially at this point, the loading has been completed, and daratumumab at this setting is typically once a month. So the LYRIS study showed that the continuing of DARA at a maintenance schedule did lead to deepening of responses. So it's another option, and I think particularly there's a lot of excitement about subcutaneous daratumumab becoming approved. That'll be great. That'll be great for patients to be able to go into the hospital, get a squirt of DARA in their abdomen, go home once a month. The treatment approach in relapsed myeloma starts with the choice of the backbone regimen, and the two large categories of studies that have been done historically were either RD backbone or VD backbone. So if somebody was on lenalidomide maintenance, technically they would be ineligible for those RD backbone studies, and so VD backbone study might be preferred. However, there's also a lot of data now coming out that pomalidomide and carfilzomib, when used in early relapses, may also be beneficial. Historically, these two drugs were saved for later stages, but I think the data are quite compelling that if you use these in earlier relapses, these are going to give better responses in PFS than just sticking to more len in a patient who's already progressing on a low dose, or bortezomib, which the challenge is giving twice-weekly bortezomib is hard to do. And a good evidence of that is most of the bortezomib dex backbone studies gave bortezomib till progression. The one exception is Castor, where bortezomib dex was a fixed duration of 6 cycles. And what's interesting is that the median PFS for fixed duration versus treating to progression is almost identical. The range of PFS rate is approximately 7 to 9 months, and the Castor's PFS is right there at 7 months. And I think what that tells us is it's hard to give twice-weekly bortezomib and dex in the real world till progression because of the risk of neuropathy. And so I think those are the reasons why pomalidomide and carfilzomib in this early setting might be usable. And so examples of these regimens would be the Optimism study, which showed that PVD was superior to VD, and also the initial 1001 study, which showed that daratumumab in combination with carfilzomib and dex was associated with good outcomes. And that has now been confirmed in a large randomized phase 3 study known as CANDOR, which showed that the addition of dara to carfilzomib and dex at 56 milligrams per meter squared twice weekly resulted in superior response rates in PFS with a hazard ratio of 0.6. So I think the treatments of relapsed disease patients is changing with these earlier use of our drugs. And luckily, we have a lot of exciting agents. So again, that concern about using these early drugs, I don't think is needed in the sense that we have a lot of promising agents, in particular the anti-BCMA therapies, that may be moving up very quickly.